All right, thank you for joining today's event on prior authorization of repetitive scheduled non-emergent ambulance transports. So the RSNAT program, the prior authorization RSNAT program. My name is Mary Sue Gardner, and I'm a registered nurse on the Provider Outreach and Education Department. And I'm going to be your facilitator for today's event. I'm also joined by other members of Provider Outreach and Education, as well as Medical Review, who are going to be helping with the chat, as well as the question and answers in today's call. Some additional housekeeping issues I want to go over. As we get started, on our website, WPSGHA.com, we have a training center. Hopefully this is where you all went to register for this live event. In our training center, you have access to training materials, you have the ability to register for any upcoming events, as well as access our encores, which are our recordings of our live events. We post our most recent encores to our training center and have a built-in YouTube player on our website so you can watch these events without having to go to YouTube. These encores are generally available on our training center page for around 60 to 90 days and are always available on our YouTube page until more current information, happens to replace it. To find our training center, you go to WPSGHA.com and then you click on the training center from the top navigation and you're going to find that live events tab. If you have any feedback about your experience today, there's going to be several opportunities during and after the event to take the survey. If you happen to be listening as an encore to this event, watch for a survey link to pop up at the top of the screen at various points throughout the event. And also at the end of the event, there's going to be a link at the end and also a link in the description. The CMS Qualtrics survey is your opportunity to give us feedback on our event, whether you're participating live or you're listening as an encore. We want to know about your experience with this event. And the survey is your opportunity to not only tell us about your satisfaction with our event, but also to let us know what additional education you want us to provide in the future. So during all of our presentations, we have to give our disclaimer, and our disclaimer basically says we prepared this as a tool to assist you in our Medicare provider community to understand the laws, rules, regulations as they are about the prior authorization process of RSNAT services. But know that Medicare rules often change. So it's your responsibility to make sure on your date of service that you are following the most current laws, rules, and regulations as they stand. We're going to give you answers today based on the laws, rules, and regulations as they are today. But Medicare always has final coverage determination. So make sure you access CMS's website for the most current laws, rules, and regulations. And we ask that you do not audio or video record this event. We are actually doing that for you. We will post it on our YouTube page as an encore of today's event. So Medicare's full acronyms, acronym soup, we like to refer to it as. These are some of the most common acronyms in the RSNAT program and things that I may or may not use today. So if an acronym comes across your screen and you don't recognize it, please refer back to this page. Or if it's not listed on the page and I happen to spurt out one of the hundreds of Medicare acronyms, just go ahead and place that in the chat and one of my co-workers will be happy to assist you with the meaning. All right, my objective for today is that you learn about the coverage criteria for using the repetitive scheduled non-emergent ambulance transport prior authorization program. And I want you to understand about some of the future changes that are coming to the program as well. So in order to achieve this objective, we're going to go over the current coverage criteria. We're going to talk about those new updates. We're going to go over some review findings and best practices, and then we're going to end with allowing you some time for questions and answers, should you have any. So let's start with coverage criteria. First and foremost, ambulance is a transportation benefit. So no transport, no benefit. The medical necessity requirements for Medicare coverage of ambulance services, those are set forth in the Code of Federal Regulations, or the CFR. So 42 CFR 410.40. So that's where you're going to find the Medicare coverage information. So Medicare covers ambulance services, including air ambulance, and that's by fixed wing and rotary wing, when they're furnished to a beneficiary whose medical condition is such that other means of transportation are contraindicated. So no other way of transporting that patient would be okay. They would be contraindicated to that patient's life and health. The beneficiary's condition must require both ambulance transportation, so it must need your transport by that means, and that patient must need the level of service that you're going to provide in order for you to bill the services to us and to be considered medically necessary. So in addition to the medical necessity requirements, the service must meet all other Medicare coverage and payment requirements. And that includes the requirements related to origin and destination, vehicle and staff requirements, and even your billing reporting requirements. So the easiest way to think of what constitutes medical necessity of an ambulance transport is it for Fred today? Does Fred going in an ambulance, is that the only safe means today on the day of transport for him to transfer from point A to point B? If it's not, then perhaps the service is not for Fred today, meaning it's not medically necessary for Fred to have an ambulance transport today. All right, non-emergent transportation by ambulance can be appropriate in a couple situations. First, the beneficiary is bed confined, and it's documented that the beneficiary's condition is such that other methods of transportation, again, are contraindicated. The beneficiary's medical condition, regardless of bed confinement status, that is such that transportation by ambulance is medically required. So thus the bed confinement is not the sole criterion in determining the medical necessity of the ambulance transportation. It's just one factor that's considered in medical necessity. As we move on, let's talk about bed confinement. So under Medicare guidelines, Medicare defines bed confinement as a person that is unable to get up from the bed without assistance. So the other indication, the beneficiary is unable to ambulate. And finally, the beneficiary is unable to sit in a chair or wheelchair. So we need to consider it when we're considering if your patient is bed confinement, make sure it's not just synonymous with bed rest. Like Medicare ambulance is not for someone necessarily that is on bed rest unless there is other medical conditions that warrant it. But in order to use the bed confined, we have to see that the patient either is unable to get out of bed without assistance, unable to ambulate, and unable to sit in a chair or wheelchair safely. So we have several programs that we have done recently on ambulance transports, on ambulance coverage criteria, ambulance documentation, and we do encourage you to go back into the encores and take a look at some of those if you want additional information on overall ambulance coverage criteria. I wanted to hit on that briefly before we get in and really start talking about the repetitive scheduled non-emergent ambulance program and what that is and how that affects you as a provider. So a repetitive ambulance service is actually defined as a medically necessary ambulance transport that's furnished in 3 or more round trips during a 10-day period, or at least 1 round trip per once a week for at least 3 weeks. Get myself tongue-tied there. All right, so under the Medicare prior authorization process, this is actually a voluntary program. So it is subject to prepay medical review after first 3 round trips. So if you as an ambulance supplier decide to not participate in the prior authorization program, please know that you can perform 3 round trips before your next claim is going to hit, and you're going to have to submit documentation, and it is subject to prepay medical review after 3 round trips. All right, so the model again establishes a prior authorization process for these repetitive scheduled non-emergent ambulance transports. And we do that to make sure that everything is in compliance with Medicare policies while you're still maintaining and improving quality of care for patients. So a prior authorization process, it doesn't create any new documentation requirements. It really requires all the same information that's already in place and already required by Medicare, you know, for payment purposes. As we move on, who is included in this model? So all independent ambulance suppliers that are not institutionally based. So you are not based and owned by a facility like a hospital. So you must be providing Medicare Part B covered ambulance services for your patients. You must bill your claims on a CMS 1500 or 837P electronic equivalent, and that's the Part B Medicare billing world. And you can't be under current review by the UPIC. So let's review that again using some of the information from the last slide as well. If you are an independent ambulance provider, not institutionally based, and you're transporting a Medicare patient on a repetitive scheduled non-emergent ambulance transport, and there's going to be 6 or more one-way trips in 10 days, or at least 2 one-way trips per week for at least 3 weeks, then this prior authorization process is for you. Again, remember, prior authorization is voluntary, but if you choose to bypass the process, your claims for those repetitive transports of that beneficiary will be subject to manual medical review after your first 3 round trips. So the HCPCS codes that are included in this model are the A0426, and that is the ALS transport, and the A0428 for the BLS transport. It does not include a mileage code. So you're receiving a provisional affirmation on the transport code and the medical necessity of that upcoming level at that service, at that level of service. So let's review the number of trips under the RSNAT program. CMS allows us as a MAC to affirm up to 40 round trips, which means 80 one-ways, in a 60-day period. If you plan to transport the patient more than this, you'll need to seek additional provisional affirmations for each 60-day period. Remember, the number of requests that we authorize is in one-way trips. Now, there's always rules and then there's exceptions to the rules. There is special consideration that a MAC can make for chronic medical conditions, for your beneficiaries that have these chronic medical conditions. So the MAC may consider extending affirmation period for beneficiaries with chronic medical conditions and those conditions that are deemed not likely to improve over time. Your medical records must clearly indicate that this patient has a medical condition that's chronic, and as the MAC, we must establish through at least 2 previous prior authorization review requests that the beneficiary's medical condition has not changed or that it has deteriorated from the previous requests. And if that's happening, we can extend the affirmation period. The decision would allow the extended affirmation period by the MAC from the standard 40 round trips or 80 one-way trips. And we could actually authorize up to 120 round trips or 240 one-way trips in a 180-day period. So again, that can't be requested by you as the supplier, but it's something that we as a MAC can grant if we've done repetitive, or we've seen that you've done at least 2 prior repetitive transports and your patient's condition is chronic and possibly continuing to debilitate. That's something we have the ability to do for you. All right, we're going to move on with submitting a request. So on this slide is a basic form on the prior authorization request. It looks like this, and we're going to go out and take a look at it. But you have several options on submitting your request. You can download and complete a hard copy request that looks like this again, and you can send that in via mail or via fax, even ESMD, but you also have the opportunity to submit electronically through our secure portal. You can submit electronically through ESMD as well. We're going to go out and link to our website, and I'm going to show you the form as well as where you can find the information on the portal. I can't show you how to complete it in the portal because I don't have access to our secure portal to show you that, but I can show you how to find it. Now, I have embedded a link to in this picture to our website. I'm going to bring that up now. All right, and that link is going to take me straight to the request form. But I am going to show you, I'm going to just go to WPSGHA.com, and I'm going to show you how to actually find that prior authorization request form. So when you go to WPS or med.WPSGHA.com, either way will take you there. I'm going to choose one of our Part B side jurisdictions, so either the J5 jurisdiction Part B or the J8 jurisdiction Part B, because this is a Part B process. The quickest way is going to be to select the forms. I'm going to scroll down under forms to prior authorization. And here is the prior authorization RSNAT form. So when this form pops up, I can go ahead and download it. I'm just going to skip over here since I already have gone through that process. So this is what our form currently looks like. So you're going to fill out this form completely if you are submitting it via mail, via fax, etc. So is this an initial request? So the first time you're requesting it? Or is this a resubmission, meaning you've requested before, but maybe you did not receive an affirmed decision. Maybe that decision was non-affirmed, so you had to gather more information and resubmit. An expedited request is done only when the time that it takes for us to complete the review would jeopardize the life and health of the beneficiary. This is going away. So come January, this will no longer be here. And we'll kind of talk about that as we go through the process as well. But CMS has said, you know, there's no need for an expedited review when these are non-emergent, repetitive, scheduled transport. So something you're doing in the future. Also, you have the ability to, you know, make those requests after you have already started the transports. Because even if you've started and you bill, you can bill up to 3 before we're even going to request anything. So there's no need for this anymore. So please note that that will be going away. All right, so you want to continue with the number of transports you're requesting. Remember that a round trip is 2 transports. You want to list this in one-way transports. How many one-ways are you going to be providing? When is your 60-day period starting? What procedure codes? So are you doing the ALS transports? Or are you doing your BLS transports? Any modifiers that are necessary as well. And then of course we get into all the information about who you are as the ambulance supplier, and you've got to give us all this information. Your name, your MPI, your address, what state you are garaged in. That becomes important in case we figure out that you happen to submit a request to us as your MAC, and perhaps we're not your MAC based on what state your ambulance is actually garaged in. Then we have to have all the beneficiary information, including the Medicare beneficiary identifier of that patient, or MBI of that patient, because the prior authorization request will stay with that patient. Again, certifying information on, or information on your certifying provider, and then information on who you are that's making the request. In case we have questions, we need to reach out to you. Who can we send the decision back to, etc. And then depending on where you are, if you're, I happen to pull up J5. So then this gives us the J5 information on if you need to mail it and you're going to send via United States Postal Service, USPS, or if you're sending like overnight, like FedEx, UPS, etc., where you would send it. Now remember, this one is specific to J5 because that just happened to be the first jurisdiction listed, and that's the one that I chose. All right, let's jump back to the slide deck for just a little bit. So, oops, wait a minute. Before we jump back to the slide deck, I'm so sorry. I did say that I was going to show you where to find this information in the provider user manual as well, because I can't log into the secure side of our portal, but I can show you right now what it looks like if you're going to fill out the form on the portal. So I'm going to scroll down here to my correspondences, and I'm going to go to prior authorization. And you can see there's a couple of prior authorization programs under Medicare that we as your MAC are part of. and specifically the RSNAT is what we're concerned with. So under your correspondences, you're going to have something right now that says prior authorization, but please note our secure side of our portal is being updated as well. So it may have a little bit different look or feel, but you're still going to find your information under your correspondences. So you go to prior authorization, and I'm going to scroll down in this manual to the information about the RSNAT. And you can see right here, this is for the RSNAT requests. So then the prior authorization request is going to look a lot like this. So you're going to have your service location, you're going to put in the type of prior authorization request, which means you're going to choose RSNAT in this process. Then it's going to give you the information just like on the hard copy form. Supplier PTAN, your address, city, state, zip code, where is it garaged, Benny information, requester information, certifying physician information, etc. And then instead of filling out that hard copy form, you've already filled it out electronically, and then you can go ahead and upload the rest of your documentation and submit it through the provider portal. All right. So going back, let's move on and talk about the physician certification statement. Remember, a condition of coverage of repetitive scheduled non-emergent ambulance transports is that the patient must be under the care of a physician, and the physician must order and certify the need for that RSNAT transport. So why does the physician feel that the patient or the beneficiary must be transported by ambulance? These are like questions that they're answering. Why is it the only safe means of transport for that patient on these specific days? So again, basically the physician's got to help you support the medical necessity. There isn't any specific form. However, we have made a sample PCS form that we invite our providers to consider adopting and updating their physician certification statement forms to make sure your physicians are really supporting the medical necessity. Remember, just because the physician says the transportation by ambulance must be done doesn't make it fully medically necessary. The documentation at the time of transport must support that it was for Fred today, meaning that all other means of transportation on that day for Fred are contraindicated. So let's jump back to our website and take a quick look at this sample PCS form. And again, I've attached a link right here for you. But one other way that you can find this, even though I'm on here, but I'm just going to go back as if I were not, and I'm going to write physician certification form. And it comes up physician certification statement. You see I had, I put in form, it says statement, but it got me to the same place. I would go ahead and download that. And then again, here we've created a form for you as a sample to help our providers, to help our physicians make sure they're capturing the information that will help support the medical necessity of a service. So again, patient information, date of birth, MBI, all of that kind of information. Who's a physician? We have origin, destination. Is a patient going to the closest appropriate facility for them for the services that they need? And if not, why is transport to a more distant facility required? So maybe that facility does not do the type of chemo that this patient needs. I don't know, I just made that up. But if it's further, tell us why it's further. Again, a little bit of information on the transport itself. And then down here, we get into the medical necessity questionnaire. And this is the stuff that really helps beef up the physician certification statement to let us know, oh yeah, it does need an ambulance. Oh yes, it does need an EMT to do this. So this is where your physician's saying to the emergency medical technicians and staff, what do you need to do for my patient during transport? What's going on with this patient, and what are things that need to be monitored, observed, checked, administered, etc. during transport. So it starts with just, is the patient bed confined, or can they not sit in a wheelchair or transport van, you know, because of maybe they have paralysis, maybe they have contractures, maybe they have other illnesses or injuries that make them not able to actually sit. Are there any special handlings? Do we have things like decubitus ulcers or fractures that require us to have, you know, a sideline position for this patient to transport? So if there is any anatomical positioning that needs to be supervised during the transport, what is it and why? And then again, you know, things like decreased level of consciousness, and then we move on to like, are restraints required? Are there chemical restraints? Is the person seizure prone? Are they ventilator dependent? If they are, what kind of settings, monitoring, etc. So this, it seems like a lot, but we tried to give you as much information in this short form to really help support why transportation by any other means would be contraindicated to this beneficiary during this block of services. And then again, it allows for the physician's signature, etc. So as I jump back into our slide presentation, let's move on and talk about some of the documentation that you need to include with your request. So the documentation that should be included when you submit a prior authorization request, first and foremost, is that physician certification form or statement, just like the one we just saw. If yours don't give that detailed of information, you might be doing yourself some injustice. So you might want to reconsider adopting a physician certification form, such as the sample that we have, or modifying your current form, you know, to include a lot of that information that I showed you. Additionally, we need documentation from the medical records to also support the medical necessity. So that may be information from the physician's office, that may be information from dialysis centers or cancer treatment centers, etc. Things that help support that it's medically necessary for this person during this block of time to transport via ambulance, because XYZ needs to be monitored, observed, administered, etc. We need that origin and destination information. So where are they being picked up from? Where are they going? And again, if you use a form like the one I showed you that we have a sample of, that contains that information as well. And then anything else, any other relevant documentation that you have that helps support medical necessity of your patient. Once you've gathered all your documentation, you have a couple ways you can submit it. Again, and we kind of went over these. The preferred way is through the secure portal. This is the quickest way to get those records to us. And as I showed you before, you would complete that request form through the portal and then upload the documentation to support your RSNAT transports. However, if you can't submit electronically, either through the portal or ESMD, you can send via fax or you can even mail it or use, you know, a delivery service. If you go to our website, you can also find submission information. I'm going to just link back out there really quick, and we're going to go, I'm going to act like I just came in, just so you guys know. I'm going to go to WPSGHA.com. I'm going to choose Topic Center, and I'm going to choose Medical Review. And again, I'm still in Part B. I'm going to scroll down to Prior Authorization. I'm going to choose the RSNAT. And here we give you all sorts of information about the program, including how to submit it and ways to submit it. So know that we've included that information on there as well. So again, this will link you out to the cover sheet depending on if you're in J5 or J8 Part B. So make sure you're in the right jurisdiction. And we've given you fax number, we've given you mailing number or addresses, etc. All right. As we move on, there we go. Let's talk about the review. So once we receive your records, we will review them to determine if their request will be provisionally affirmed based on the records that you submitted. There's a few things changing again with the reviews that are coming up. First, as I mentioned previously, when we looked at the form, the expedited review is going to be going away. That's because, again, these transports just aren't a reason to expedite. They're non-emergent future transports. You can even submit up to 3 round trips, you know, in the process without any worry. And your 4th one is going to be medically reviewed. So just know that that is going to go away. It was determined that really there should never be a reason for that. And so, yeah, that's just gone. Next, our review time frame as a MAC is being shortened from 10 business days to 7 calendar days. Please note, there was a misprint on the slide up here, and I think this said calendar days as well. So if you would just note and change that, this should say 10 business days and not calendar days. All right, so once we receive the documentation, we have several options as to what to do with it once we reviewed it. We can either provisionally affirm it, we can non-affirm it, or we can reject it. So let's talk about these decisions. The provisional affirmations, those are preliminary findings that a future claim submitted to Medicare is likely to meet the coverage coding payment requirements. So we can provisionally affirm for all the days that are requested, or we can even give a partial affirmation, meaning we're going to allow some but not all of the dates requested. It can be non-affirm, which means that we are not going to allow any of the days requested because it doesn't look like from the documentation that you supplied that the future claims are going to meet the coverage and coding criteria. And it can also be rejected. So rejected prior authorization is when a MAC is unable to process that request due to an incomplete or invalid information. We will notify the submitter that their request was rejected and the reason why. And rejected prior authorizations aren't denials and are not reviewed for medical necessity. Some of the reasons for rejections are because we're not your MAC. That could be a reason. You submitted the information to the incorrect MAC. So remember, the location is based on where your ambulance supplier is garaged. Another reason could be that the patient doesn't have traditional Medicare. Maybe they have a Medicare Advantage plan, and so they've chosen to give up their traditional Medicare. If that's the case, you need to contact the MA plan and see if that MA plan has a prior authorization program. We don't know if they do or not. They administer their programs in different ways. That is not part of Medicare. Maybe the request contained invalid or missing Medicare beneficiary identifier. So maybe the MBI number for the patient isn't found in the Medicare system. Maybe it was fat fingered, whatever the case may be. If we don't have that information, we can't match it up to a beneficiary, then you know, we would reject it. And yet another example could be there's already a prior authorization on file for the same beneficiary, either with the same ambulance supplier, so there's already a UTN or a unique tracking number that's already in use, or by another ambulance supplier that's already has their own UTN in use. So let's move on and talk about these a little bit more. Provisional affirmation. Once we decide we're going to provisionally affirm the request, we will issue you a decision letter. That decision letter also contains the unique tracking number, or UTN, that must be included on your future billed claims. That decision letter is going to come back to you in the same manner as you requested. So it can be sent via fax, it can be placed in the portal, it can be mailed. We also send a decision letter to the beneficiary so they know the decision as well. As a supplier, you would render your services, you would maintain all your transport records, and when you submit your claim, then again, you include that UTN on the claim. If we don't affirm a decision, you'll still get a UTN number. That letter will explain why the decision was made to not affirm your request. Again, just as with affirmed, we'll send it back to you, and we will notify the beneficiary as well. So as a supplier, you can resubmit a complete request that includes additional information as many times as you need to. You must include your initial UTM, so that one that came on the non-affirmed decision letter. So you need to include that with each of your subsequent requests. And you do that if you feel that your services are indeed medically necessary for the beneficiary to transport in that way. And maybe something was missing. So in that case, you would have to make a complete package again of all documentation, include whatever was missing with the prior request, submit it, and include the unique tracking number that you got with the non-affirmed decision. All right. So again, as I mentioned with the prior slide, you can submit subsequent submissions to correct any errors or omissions that were identified in a non-affirmed decision letter. And each request must stand alone. So you have to submit it all over again. So, which means that the package of information you initially included has to be submitted again, and then include any additional documentation that helps support your medically necessary services. Don't stop your transports during this time. So if something were to happen, continue doing your transports. You just hold your claims from submission until you get a notification of decision. Make sure you include that UTN from the notification of decision letter. All right, and then rejected. As I noted prior, if your request was rejected, we're going to tell you why. So as a supplier, it's really important that you review this information so that you can correct this issue. Make sure you correct the issue before you submit a request again. If your rejection was an initial request, your next request is also going to be marked as an initial. So this is not a resubmission. So this is another initial request. Again, remember, just keep them separate because a rejection with submitting again is not a resubmission from a non-affirmed decision. All right. And then a little bit of information on the unique tracking number before we end with discussion on review findings. So the unique tracking that you receive is valid for the affirmed time period. Generally 60 days. As a MAC, that's what we generally grant, is 60 days. And remember, in some chronic conditions, after going through 2 other prior reviews, as a MAC, we could consider a longer time period. That isn't always going to happen, but do know we have that ability. So when you reach the end of your 60-day period and you need to continue doing transports, you're going to need to submit for a new prior authorization request. And when that's granted, you're going to get a new unique tracking number for your next 60-day period of time. So your UTN, it must be included on your claim form as well. So your 837 professional claim or the CMS 1500, however you're submitting. Remember, it's good for that 60-day period of time that you requested and only longer if granted by us as your MAC. All right, so these next couple slides are just some of the issues and errors that we commonly see in prior authorization requests that make them non-affirmed on initial review. And I'm just going to go over these quickly and hopefully help you avoid these issues. So your physician certification statement does not list a reason for bed confinement. So remember, it's not synonymous with bed rest. Your physician needs to tell us why this person is bed confined or why they need to transport via stretcher. The physician certification does not identify the medical interventions or the monitoring or what services that require an EMT during transport. So again, think about that sample that I showed you and all of those services, you know, boxes that your physicians can write in, give us the additional information, can check what they want monitored, etc. That is going to so much help you avoid these reasonings. Documentation that doesn't support the statements made on the physician certification statement. So the condition of the patient documented does not support what the physician is certifying the actual condition of the patient is. So if it's conflicting, you know, that may not look favorably on our affirmed or our reviews. The physician certification statement was submitted without supporting documentation. So we got a statement, but there was nothing else to help support that. The signature on the physician certification statement doesn't include physician credentials. So the physician needs to sign it. It needs to be legible. The physician can handwrite and then have a sloppy signature above it. That's fine as long as we can see who it is and we have credentials that support. Is this person an MD? Are they a DO? Those are things that we need to see. If it just says John Doe, we don't know that John Doe is a physician. We have to know that the dates on the PSC are within that 60-day period. So if the dates on that are outside that 60-day period being requested, that's not going to be affirmed. And then finally, the physician certification that's signed by someone other than a physician. So in this case, in the repetitive scheduled non-emergent ambulance transports, you have to have a physician signature. It cannot be signed by someone else. So again, we're going to be looking for that physician signature within the documentation. And then here are just various resources that I have provided. And I see, and I apologize to all of you that are involved, I have already gone over time. I do see one question that's come in, and let me look at it real quick. We have many transports that are non-emergent transports, but do not fall under RSNAT, like the patient discharged from a hospital. These claims are being denied, stating that the physician certification is invalid because a physician didn't sign the physician, not a requirement when the physician is not repetitive, or they are denying because another ambulance service has authorization number for the patient. Okay, so Tanya, I see your question. If you are in a position and you are transporting a patient, it's a non-emergent, non-scheduled transport, and you don't have a physician that is able to, or you're not able to get the physician certification, you can have a non-physician certification statement. So in that case, I would just be careful about the wording on the certification statement to make sure that we understand that this is a certification statement from a non-physician. And 42 Code of Regulations 410.40 has information on the difference between the physician certification and the non-physician certification statement. So I will also follow up with any additional information to you on that. All right, again, I apologize for being over time. I was just taking my time and did not realize that we had run into our time. So I'm just going to then finish up, give you a little bit of information. You're going to get an email, which is probably already in your inboxes. It's going to have your proof of attendance. And if you need to submit for continuing education, it's going to have your continuing education credits on that. It's also going to have a link to the survey if you need an additional link to the survey. And Jennifer's going to place a link to the survey in the chat as well. If you find you have follow-up questions, you can go ahead and send those to us at wps.gha.education@wpsic.com. And in the subject line, you're just going to place today's topic. So you're just going to put RSNAT services, or RSNAT education, or something about RSNAT. If you have claim specific questions, you have to send those to customer service. I don't want you to send any PHI or PII to an email box. We would hate for that to happen. And we don't have access to the systems to look up your claims anyway. So you really have to go back to customer service with those. Again, as I stated before, let us know what you think. Again, I apologize for going over time here, but when the webinar closes, you're going to be directed to an external site that looks like that, and it's going to give you the opportunity to take the survey. You can also, if you're listening to the encore of this event, you'll also at the end get a opportunity to take the survey for the encore of this event. All right, and then again, on behalf of Jennifer and myself and Medical Review, we want to thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.